Hello, I'm Mark Clemens. I'm an Associate Vice President of Perioperative Services, as well as an Associate Professor of Plastic Surgery at MD Anderson Cancer Center. And I'm very pleased to present to you best practice techniques in breast implant reconstruction. I also want to thank the organizers for the fourth Cali Breast Meeting. I wish we could be there in person, but I'm very excited to be able to share with you our algorithms as well as our best research on this subject. Thank you.
Today we'll be covering best practices in implant breast reconstruction. I want to first note that I have no financial conflicts of interest, though MD Anderson does participate in US FDA clinical trials. I want to start with our algorithm for treatment of patients with breast implants as well as autologous reconstruction, which basically breaks down into two separate pathways based upon the need for radiation therapy to the right, as well as no radiation therapy, which can be reconstructed with a two-stage tissue expander to implant or a direct implant reconstruction. Many times the decision to go for radiation is based on tumor size or lymph node involvement. If we look at patients that have been radiated, we usually reconstruct about 75% of those with a complete autologous reconstruction, saving an implant for only about 25% of patients that have been radiated. For patients that are non-radiated, implant reconstruction approaches 90%. If we look at how we reconstruct patients, the standard of care at MD Anderson is neoadjuvant chemotherapy, receiving chemotherapy before the mastectomy. At time of mastectomy, we will usually perform a reconstruction that is pre-pectoral on top of the muscle. This has been a real shift in the last 3 to 4 years to doing all of our reconstructions on top of the muscle with either a tissue expander temporarily, followed by a final implant. If the patient does require radiation therapy, we will usually save an implant or an autologous reconstruction for 6 months after that. And these patients with radiation have high rates of fat grafting. This is a video that's just going to demonstrate how we walk through a typical implant-based reconstruction in a complicated radiated patient. This patient has had a previous lumpectomy of the right breast. You can notice the scar on the medial aspect. And to decrease thermal damage during the procedure, our breast surgeons do prefer to use a peak plasma blade, which has less thermal damage. You can see that the nipple is well perfused at the completion of the mastectomy. It's incredibly important to maintain the intercostal perforators and off of the internal mammary chain. You can see in the picture the arborization of the blood vessels demonstrating a well-perfused flap. This is incredibly important to maintain. Postoperatively, because infection is a high risk in these patients, we will usually utilize drains as well as antibiotic-eluting patches around the drain sites. And as you can see, the nipple is very well perfused at the completion of the mastectomy. We feel comfortable doing a direct implant reconstruction utilizing acellular dermal matrix as a protein mesh to support the implant. And it's also, I'll note that this is in a pre-pectoral or on top of the muscle reconstruction. You can see in this patient how she looks immediately postoperatively. She has done quite well. She has fairly good symmetry, and she is reconstructed in one single approach. As I mentioned before, fat grafting is becoming more and more common, particularly in our radiated patients. This usually does require a fair amount of overcorrection. We do feel that this is oncologically safe with equal recurrence rates. We do warn patients, though, particularly in lumpectomy defects, that it may subject them to increased need for biopsies due to appearance of calcifications on mammography. This demonstrates what it looks like doing a prepectoral reconstruction utilizing a allograft acellular dermal matrix. We usually do a wrap on the back table, wrapping the protein mesh around the device. Then this goes into the patient in a prepectoral position. To decrease pressure on the skin flaps, I will usually utilize temporary air fill of my tissue expanders, and usually filling up the tissue expanders about halfway. At MD Anderson, we published the largest prospective study of breast implant patients to date, which was about 100,000 patients. This was described recently in a meta-analysis as the largest and most comprehensive epidemiological study of patient safety and implant-specific outcomes for breast implants in the literature. The study represented 3,200 centers. The day that it came out, it was tweeted out on Twitter by the FDA commissioner at the time, Scott Gottlieb. Based on the results, he called for a review of breast implant safety to be performed by the FDA in 2019 to look at all possible sequelae, both common and rare, of breast implants. I want to share with you some of the outcomes of this study. So this was 100,000 patients, with the vast majority being cosmetic augmentations. The good news is that patient-reported outcomes were incredibly high, with most patients very happy, even long-term, that they had received breast implants, and higher for silicone implants. However, there were both short-term and long-term consequences. Rupture was higher for saline, capsular contracture was higher for silicone, and all local complications were higher in revisionary surgery. If we go 7 years out, we see that nearly 1 in 8 patients will develop capsular contracture, and this continues to steadily increase over time. What was surprising is that about 1 in 5 augmentation patients will have chronic pain long-term, and 1 in 3 patients will have a dull, achy feeling to the chest wall long-term in reconstruction. And I think that this post-mastectomy pain has not been properly addressed in the past, and we could do a better job doing that. Our FDA study showed high reoperation rates. It was actually 1 in 4 for primary reconstruction, mostly driven by capsular contracture, as well as patients requesting size changes. Overall, reoperation was about 1 in 4 for primary reconstruction, and as high as 1 in 2 for primary reconstruction for overall complications. If we look at rupture rates of implants, we see that they are quite high across all of the manufacturers at 10 years, anywhere from about 10% up to 25%. Also noted in this very large study was some patients developing systemic disease. Sjogren's, scleroderma, rheumatoid arthritis were statistically significant, and this was true of both Mentor implants as well as Allergan implants. Based on this, the FDA put together an advisory of things to consider before getting breast implants, and they recommend these be explained to all patients that are considering breast implants. Number 1, they are not lifetime devices. They do have complications with financial costs. Manufacturer package inserts should be given to all patients so that they can read these themselves. Removing implants results in undesirable cosmetic changes. Even despite this, we are seeing increases in explantation, and they encourage patients to regularly monitor with MRI or ultrasound evaluation after 5 years, and then every 3 years thereafter. They also warn about the risk of breast implant-associated anaplastic large cell lymphoma occurring with textured implants. They also notice that some patients have nondescript complaints, which is categorized as breast implant illness. And they also warn that breast reconstruction often involves protein mesh, and that the benefit of mesh has not been approved yet by the FDA. Subsequent to this, a number of breast implant registries have developed around the world. Um, and we have one in the United States. And we also encourage all physicians to report their breast implant outcomes uh, nationally to these registries. We can see that some of the largest and most robust registries to date are in the Netherlands, Australia, and in England. Based on this, in 2019, on July 24th, the FDA performed a Class 1 device recall of Allergan textured implants. And the reason why was based upon the data that we had presented that breast implant ALCL can occur with patients with a textured surface breast implant. At the time, the FDA noted that there was 733 unique cases of breast implant ALCL cases worldwide, with about 30 in Colombia. And because of this, there's been 36 deaths worldwide. When we looked at implant manufacturer, we saw that Allergan manufacturer was responsible for 91% of world cases when the device was known. Because of this, the FDA called for a, um, a class 1 device recall on this subject. Also, after this, the FDA has asked for um, changes in breast implant practice, calling for black box warnings on all breast implants, as well as the idea of having a standardized patient checklist to be performed when patients are getting a breast implant. They also warn of the risk of breast implant ALCL, as well as the possible association with systemic symptoms. We talked about the risk of breast implant ALCL, and I also want to point out that the risk of breast implant ALCL with Allergan has been shown to be a risk of about 1 in 2,200 for Allergan BioCell textured implants. This is important because Allergan BioCell was the #1 selling breast implant in the world prior to the recall, as well as the most common implant placed in South America. If we look around the world, we also see that the risk of breast implant ALCL is particularly high, both in New Zealand as well as in the Netherlands. The highest reported incident right now is at Memorial Sloan Kettering, where Dr. Peter Cordero reports in a 26-year practice of 5,700 implants placed, a risk of 1 in 355 developing breast implant associated anaplastic large cell lymphoma. The FDA is quick to point out that there has never been a smooth implant case of breast implant ALCL. And so therefore we do feel that smooth implants are a safe alternative for patients that are concerned about breast implant ALCL, because there has never been one to date. Because of this, we have noticed a shift in breast implant usage in the United States. This is the data from MD Anderson demonstrating that textured implants did gain in popularity about 6 years ago. They were approved in the United States in 2011. However, with the increasing risk of lymphoma associated with textured surface devices, they have completely dropped out from all usage within the United States. We also see new studies, this one out of South Korea, demonstrating that a textured surface breast implant is also associated with a higher risk of breast cancer recurrence when compared to a smooth implant. And so therefore we are seeing textured implant reconstruction plummet around the world based upon the recall and some of these studies demonstrating cancer links. If we look around the world, we do see 1,136 cases of breast implant ALCL to date, with approximately 17 cases in Colombia and 1 death of disease associated with that. The main hypothesis of why this occurs is thought to be perpetual exhaustive phagocytosis, where macrophages attempt to break down the particulate off of the surface of a textured implant, leading to an inflammatory cascade, which leads to lymphoma. We've also done studies demonstrating that the mechanism of action appears to be allergic inflammation mediated through an IL-13 cascade pathway, leading to the proliferation of lymphocytes. Based upon this, we have developed at MD Anderson best practice techniques for testing for breast implant associated ALCL, and this is through the National Comprehensive Cancer Network. The most common presentation of this lymphoma is a large fluid collection developing around a breast implant approximately a decade after receiving the implant. If this occurs, patients are encouraged to have an ultrasound evaluation that is then aspirated and tested for CD30 immunohistochemistry. That is the diagnostic test of choice for this lymphoma. If the test comes back positive, then that patient should be taken to the operating room for surgical resection. And this is just what it looks like for an ultrasound in one of these patients. This is how these patients present. The normal top one is just a benign seroma, but it can look very similar to a breast implant ALCL patient shown on the bottom. And you can see confluent staining of CD30 immunohistochemistry. The proper technique and best practices for the diagnosis of this is multiple biopsies of a capsule to look for it. And again, this is done in a symptomatic patient with a delayed seroma or in a confirmed case of breast implant ALCL. We can just demonstrate what the pathology looks like when opening up the capsule and then serially testing it. Ideally, best practice is 12 different biopsy sites from around the capsule. The treatment, again, is by NCCN guidelines, is surgical resection, which is curative in the vast majority of patients when disease is confined to the capsule. When disease is metastatic to the lymph nodes or organs, the patients usually do require systemic chemotherapy with targeted immune therapy, brentuximab vedotin, which is now first-line treatment for these patients. And so I want to leave you with these final key points, which is that breast implants are safe with both high patient satisfaction and known adverse events. Implants are not lifetime devices. We should continually monitor the long-term safety of breast implants and make sure that all patients and physicians are aware of any possible harms. And this ensures that patients and their healthcare providers weigh potential risks and benefits together. If you'd like more information on breast implant ALCL, I would direct you to plasticsurgery.org/ALCL, where we have resources for both physicians as well as patients. And I would also invite you to attend our third World Consensus Conference on breast implant ALCL. It'll be combined with the 7th International Breast Surgery Workshop to be held in Rome, Italy, this October 8th and 9th, 2021. It will also be available both in person as well as virtual format. If you are not able to make the trip, you can watch this in real time. Thank you again, and I appreciate your interest today.